Hello and welcome everyone. My name is Matt Shepard. I'll be your moderator for today's Team Gleason Center for Medicare Advocacy Town Hall Q&A, and I'm here with Center for Medicare Advocacy Associate Director Kathy Holt and Attorney Madeline Korber. Say hi, guys.
Hi.
Perfect. This session is brought to you as part of the joint Team Gleason Center for Medicare Advocacy Medicare and Home Health Initiative to help people living with ALS understand Medicare, including the home health benefit, and to maximize access to coverage and care. A little obligatory info about our organizations. The Center for Medicare Advocacy, as many of our audience probably know, is a nonpartisan nonprofit organization which, since its founding in 1986, has worked to obtain fair access to Medicare and quality health care for older people and people with disabilities through education, training, analytical research, advocacy, and legal assistance. The center is staffed by attorneys, advocates, nurses, and technical experts, all working for systemic change based on our daily experiences with the problems of real Medicare beneficiaries. Team Gleason's mission is to help provide individuals with neuromuscular diseases or injuries with leading-edge technology, equipment, and services, create a global conversation about ALS to ultimately find solutions and an end to the disease, and raise public awareness toward ALS by providing and documenting extraordinary life adventures for individuals with muscular diseases or injuries. The Medicare and Home Health Initiative includes 3 webinars, all now available for viewing online at medicareadvocacy.org/webinars. And thank you to all of those of you who've attended those webinars. And apologies because this might be the 4th time you've heard all this information. But to continue that information, the Medicare and Home Health Initiative also includes a dedicated email portal for those living with ALS to ask questions and share home health access stories. You can share yours at homehealth@medicareadvocacy.org. And of course, we have 2 more town hall sessions, the 2nd Wednesday of July and the 2nd Wednesday of August. And you can register for those right now below the Gleason webinars on our webinar page, which is again, www.medicareadvocacy.org/webinars. Once again, we are grateful to Team Gleason for their support of this important initiative. As I mentioned, our experts for today's Q&A are Center for Medicare Advocacy Associate Director Kathleen Holt and Attorney Madeline Korber. The splash screen may have said Judith Stein, but she was called away to DC. Before I let them start, however, I need to do a little of the usual presentation housekeeping. If you can hear me, great. You use the information in the email you received after you registered to log into our webinar, and you've dialed in by phone, or you have good quality working speakers on your computer or device. All great. If you use that telephone call in, we should be able to hear you when you've got questions. Otherwise, please be sure that your computer or device has a good quality mic. If you're not, it's never too late to dial in using the instructions on your confirmation email, or also available under the audio tab on the control panel that's at the right of your screen. If, as happens on occasion, you've dialed in and haven't logged into the online portion, you should still be able to hear us, but you won't see that control panel, so interacting is going to be a little hard. Normally, I would also say, so you won't see our presentation, but today things are a little bit different. This session is not going to be driven by a presentation from us or a PowerPoint. It's going to be driven by your questions, your comments, your stories. We're here to hear you, so please don't be shy today. And thank you to the several folks who already submitted questions when they registered. A little bit more on that panel as it relates to today. Please note the little picture of a hand at the left side. That will be used to indicate that you've got something to say. We have quite a few registrants, so for the bulk of the presentation, we're going to keep folks muted, but please do click on that hand icon to let me know if you want to jump in, and I'll unmute you. But if you are shy or you'd prefer not to try the audio, that control panel, as always, also has a questions section for your use. You can just type in what you want to say there, and I will relay it to the best of my abilities. So thank you all once again for attending, and I will now hand things over to Kathy and Madeline to get us going.
Terrific. Thank you so much, Matt. This is a rather new format for us, so we hope that you enjoy it and join our community as we help to answer questions for folks. I will say, in looking at some of the questions that we received from people, we realized that many of the participants, the people who have registered to be on this webinar with us, I'm not even sure what we're calling it, but this town hall meeting with us really have a lot more knowledge about how things practically work and many of the registrants are experts in your own right. And help one another. So while we will answer as many Medicare questions as we can, we encourage you, if you hear someone who has a specific question about how something works and what kind of services that people should be looking for, we'd like to do an information exchange kind of a project. So if you hear someone ask a question about something you know about, please email and say, you know, I heard Joanne's question and I have some advice to give to Joanne. Let us know, and then we can pass that information on to Joanne. We really want this to be collaborative, and the goal is to help as many people living with ALS as possible to be able to make their lives any little bit easier that can happen. So just in general, please participate, join us. We hope to answer, again, as many questions as possible, but we know there are more experts out there than just us, and we really want that to be something that's participative and that we can join together on.
And also adding to that, we definitely want to hear questions, but as well as success stories, any tips, what you're seeing out there in the community, because I often say that we hear from people who aren't receiving certain benefits. So if people have had success and have any stories, anything they'd like to add, anecdotes, we'd like to hear those as well and have it be part of the discussion.
Yeah, that's really valuable. And Maddie brings up a really great point in that we have heard from people who are in a position to amplify our message, have said to us, send us your success stories. Tell us when somebody is getting the benefits that they qualify for, let us know, because what we can do is say, this is working, this is how it's supposed to work, this is clear that Medicare will cover these benefits. And then we can use those kinds of stories, those success stories, to share with people who can make it happen, if you will. And having said that, I hope that Jean from Compassionate Care ALS is on our town hall today. I would love for Jean to call in and share her success story that she shared with us. I know Jean is registered. So Jean, if you can hear me, we would love to have you share your story of success that has happened since we did the last webinars. That would be really helpful. I also want to give a shout out to a couple of other people that I know are registered today. Jenny Gore-Dwyer, who is one of my personal ALS advocate. I'm a big fan, Jenny knows, and Jenny's a friend of mine. So, and hopefully really helping us to move the issues forward. So again, the more stories that we have, the more we can make sure that the true benefit that should be provided to folks is actually accomplished. So hi, Jenny, and please jump in if you have any news to share. And then finally, I want to mention Joanne, who we heard from last week, who had a question about when Medicare should start. And she went to Social Security last week and had a great result from that. So Joanne, if you'd like to share your story as well, we'd love to hear from you and anyone else. So what we thought we'd do today is talk about the questions that we've recently gotten from folks who have registered on our webinar. And as you know, we have in our, well, maybe you don't know, but in the last 3 webinars that we have done, we asked if people had questions, and then we posted our answers to the questions that came out of the last 3 webinars. So what we'll do is we'll start with the questions that we received from people who registered for the town hall, and we'll address those, and then we'll address your questions that you have on the phone today. And then if we have extra time, we'll go back and look at some of what we refer to as our frequently asked questions. Those are questions that we've gotten multiple requests to respond, and we'll talk about those. So that's kind of how we're going to move forward on our format today. Okay. All right, so let's see. The first question that we had asked, and this is actually very similar to the problem that Joanne came forward to us last week with, but this is a question from Lisa. And Lisa says, I got my first Social Security check. I have ALS, and am I eligible for Medicare now? And she says that she's age 62. But the reality is when she's been approved for Medicare with the diagnosis of ALS, the Medicare will start simultaneously with the cash benefits. So there's a 5-month waiting period from what Social Security determines as the onset of disability, or the date that someone became incapable of engaging in regular and continuous work activity. So in Lisa's case, if she has already started getting her Social Security benefits, then she should already at the same time be eligible to enroll in Medicare. Do you have anything that you wanted to add to that?
No, I don't think so.
Okay. Just to give you another example, sometimes Social Security does get a little confused. It's important to make sure that Social Security knows that the diagnosis is ALS, because it's unusual to not have a 24-month waiting period. But ALS and end-stage renal disease are the two diagnoses that there's been a waiver of the 24-month waiting period. So while there's a 5-month waiting period to receive Social Security, that also attaches to Medicare for everyone, but the 24-month waiting period is waived. Okay, so let's turn to another question. How far does ALS have to progress before I get home health care? Maddie, you want to?
Yes, I'll take this question. So first of all, if you qualify for home health, in order to qualify for home health care, you need to need skilled services and be homebound. These are the two primary criteria. If you qualify, you need either skilled nursing, physical therapy, occupational therapy to continue services, or skilled nursing. You could qualify. Home health care is ideally meant for beneficiaries who require skilled services but have a normal inability to leave the home. So it's required that the beneficiary be homebound. So your ALS must have progressed to a point that you would be considered homebound, which is a legal definition. It isn't bedbound. It doesn't mean that you're never leaving. The specific definition includes that you need the assistance of another person or a device in order to leave the home, or leaving the home is contraindicated. It's also required that it is a considerable and taxing effort to leave the home, and that you have a normal inability to leave. Again, as mentioned, it isn't required that you be bedbound. You are allowed to leave. However, trips outside of the home should be of infrequent and short durations. So for example, if you are going to your granddaughter's graduation, or you're going to a wedding, this doesn't disqualify you from being determined homebound. There are also certain exceptions in the law. So for example, leaving for religious activities or medical appointments automatically don't count towards that homebound determination. So if your ALS has progressed to a point where you require skilled services, your doctor has a plan of care and ordered skilled services, and that your condition is such that you could be considered homebound, then you would qualify for Medicare covered home health care.
Good. And then I would also add to that the reminder that there are no rules of thumb in Medicare. So as Maddie mentioned, you have certain criteria that you would need to meet, such as the ALS has progressed to the point where you meet the criteria of homebound, but there are no rules of thumb that say that a certain progression mark has to be met. You don't have to have like a certain vital capacity measurement or anything like that. It does have to do with it in your individual case and what your circumstances are that have you meet the criteria of that. And I guess I would also say to that sometimes people are temporarily homebound. Like maybe you've had a procedure that that prevents you from leaving home now, and then you have to recover from that procedure. So you may be considered homebound for several weeks or a month. It's going to depend on that individual circumstance. So you don't have to reach a point of being homebound forever. There are people that go on and off of home care, depending if they are able to recover from a certain procedure, for instance. Okay. Let's see. Let's go on to a question from Arlene. How do we find a company to give home health care for ALS? We have been through 3 of the preferred on the list, and I'm hoping this 3rd time will help. And then there's a question about billing code or a specific reference that's needed in order to get the services.
So, Arlene, you mentioned that you've looked on the preferred list. So I'm not sure, you might be under a Medicare Advantage plan, but first, generally the best way to find home health agencies that might be able to provide your care is if you go on Home Health Compare on Medicare.gov. And on that website, you can enter your zip code and click search, and it will list all of the home health agencies that service your zip code. We often recommend to beneficiaries who are trying to find the best home health agency, well, the best home health agency for them, that they call every home health agency on the list and discuss the plan of care, the orders from the doctor, and see what some are willing to offer. Because as we'll mention later, some agencies have more, for example, home health aides than others. So you might call one who's able to offer a couple of visits a week and another who can only offer 1 visit per week. So we recommend going on Home Health Compare and calling as many of those as you can. If you are in a Medicare Advantage plan, your options for home health agencies might be limited to only providers who take that plan. So then we recommend that you call the providers that service your area and take your plan. There is a requirement in the law that Medicare Advantage plans ensure that they have sufficient coverage that's adequate for the beneficiaries. So if you're unable to receive the coverage, none of the agencies are able to offer the services that you need, then you should speak with your plan about this and how it's not meeting your needs.
Great.
Do you have anything to add?
Yeah. I mean, I just want to mention for people that do have Medicare Advantage plans, there's a requirement that there be network adequacy in Medicare. And what that means is that within the Medicare Advantage plan, the services have to be available. So that's, if you're in a Medicare Advantage plan and you can't get these services, I would say, well, call us. But I would also say that the Medicare Advantage plan needs to understand, and either you can tell them or we can tell them that they need to provide these services.
And should you be interested in looking up the citation, that is 42 CFR, Code of Federal Regulations, section 422.112. And the Medicare Managed Care Manual also discusses that in Chapter 4.
Great. Okay, so here's another question. In bulbar onset ALS, what can I do other than record my voice? Is there anything I can do with my phone? So thank you, Lisa, for that question. So I want, again, this is in the spirit of making sure that you get as much information as possible to help answer the questions. And my fear is that we don't know what we don't know. So let me just say, from the first part of that question, what can you do other than record your voice? Our suggestion, and this is why we have this great community of people that are on the phone and others who can help, but our suggestion, our first suggestion would be to work with a speech language pathologist to make sure that you know all of the opportunities that you would have available to know what you can do as you prepare to be able to use a speech generating device, for example. And in addition to speech language pathologists, you know, if you have access to a support group or have access to care services coordinators through an ALS Association chapter, or other members of the community. Team Gleason is fabulous when it comes to knowing what there is to know about technology and speech generating devices. So, not to evade the question, but I think we want to make sure that about helping you to figure out how to do other than voice recording, that would be important. Also, speech language pathologists are very technically oriented when it comes to Medicare. So they will help to know what Medicare will pay for and what Medicare will not pay for. So with regard to the phone, I do want to kind of make a statement about this, and it's a little bit of a convoluted story, so bear with me. In Medicare, there is a limitation that says that if a piece of equipment like a phone or an air conditioner or anything, an iPad, for instance, is useful to someone who doesn't have a health impairment, then Medicare won't cover it. It doesn't make a lot, it's too rigid, doesn't make a lot of sense from the standpoint that sometimes people can use, for instance, an iPad for speech generating device, but because Medicare won't pay for an iPad, nor will they pay if someone has an iPad, they won't pay for the accessory to allow someone to have eye gaze technology. They will only pay for the eye gaze technology if it connects up to a machine that Medicare pays for. So there's a lot of rigidity in the system, and part of that is there's a concern about fraud, and there's a concern that of perception. So if we buy someone an iPad, then it will look like Medicare's just buying people iPads. It doesn't. The purpose of it isn't as important to Medicare as the fact that it could be a slippery slope. So at this point, when you, and I just wanted to raise that point, when you say, what can I do with my phone? Again, because Medicare won't pay for phones because they're useful to someone who doesn't have an impairment. And I brought up air conditioning mostly because there's a lot of people whose health conditions can be alleviated to a certain extent if they have air conditioning. Medicare still won't pay for air conditioning because it's helpful to someone who doesn't have an impairment. So in any event, that's the theory behind it. So unfortunately, until we can get Medicare to change their rules and say, from the standpoint of protecting Medicare and making sure that it does what it needs to do for everyone, they're not going to pay for practical items where you could buy an iPad for $600, but no, you have to buy a speech generating device for a lot more money. So I'm not sure if I answered your question, Lisa, but that's my advice to you at this point. You have anything to add to that?
No, it's unfortunate.
Yeah, it's sad. Okay, so here's another question. I have a waiver through my county. Do I qualify to receive physical therapy through Medicare? And this is from Robert.
So Robert, if you meet the qualifications discussed earlier, if you're homebound, you have a plan of care from your doctor, and as noted, you require these skilled physical therapy sessions, this waiver for these other services you're receiving won't affect your Medicare coverage, so you will still qualify and can receive those services.
Okay, and then I would also add a couple of things. One is that sometimes people have physical therapy that they get through their clinics. They get outpatient physical therapy, so they may not necessarily need to be homebound. They may not necessarily need to get home health physical therapy. So Medicare does cover outpatient physical therapy, like at Apple Rehab or at the clinic setting as well. And then the other suggestion that I would have for you, there's a section. Sorry, I'm not meaning to rifle through all my papers, but I wanted to show you, if I have it, it's at the very bottom. Medicare.gov has, it probably doesn't help to pull this up, but anyway, you probably can't see this, but Medicare.gov has something called helpful contacts. And you can go onto the Medicare.gov website, search for helpful contacts, and then you can select your state, so whatever state you live in, and then it will give you all kinds of resources for that state, including the state health insurance assistance programs, who know a lot about Medicaid within a state, and if they don't know it, they know how to get you in touch with the state Medicaid directors. So make sure that you're kind of knowing that you have these other resources. Medicare is a federal program, whereas Medicaid has state by state rules that are very different. Although I will also say, with regard to your question about the waiver and will Medicare pay for something, in every instance, Medicaid that administers these waiver programs is the payer of last resort. So what that means is if you have Medicare and Medicaid, that if it's possible for Medicare to cover something and pay for it, then Medicare will pay first. So the bills should go to Medicare. If Medicare denies, then it will go into the waiver payment program, so that you could get any coverage that's necessary as a secondary payer through the waiver programs. And again, I'm going to defer to having you contact your particular state to really get more in-depth information about how that works. Okay. Right, and then let's see, do we have other questions that we can answer? Matt, I think those were the questions
I think
that we got ahead of this town hall call today. So if there's anybody that you've gotten questions from, we'd love to answer them.
All right, we do have several write-ins. We have one hand raised, so you know what? We're walking the high wire. Let's try to go live and see what happens.
Great.
Sandra, are you there? Sandra, you look to be self-muted, so you'd have to click on your little telephone icon to unmute yourself for us to hear you. No?
It's not fun when it doesn't work.
Come on, Sandra.
Nope. It's all right. Sandra, you can type it in. We have lots lined up, so plenty of time. So let's instead go to one of our typed in questions. And you touched on this a little bit, but Susan is looking for a little more information. She asked if the two ladies on the panel today are affiliated directly with Team Gleason, because if so, she's very interested in what services they might provide. She is aware of voice banking, which you touched on, but unfortunately lost her voice long before that technology was available and is wondering what else there is. Thank you, says Susie.
Well, Susie, neither Maddie or I are, I shouldn't say affiliated, because in a way I am. I'm on the board of Team Gleason, but let's get in touch with Susie. I'm going to give you Liz's number. Liz will be sorry she's not on the phone today. Liz at Team Gleason is like the greatest advocate on the planet, and wants to help everybody. And Team Gleason has just an array of services that they offer. And the great thing I have to say about being on the Team Gleason board is every time we have a board meeting, I learn about the creative ways they have found to serve everybody, because their mission is to make the lives of people with ALS easier. And whatever you need, they're going to figure out a way to do it. So having given them that big shout out, I will say that please stay tuned. We'll put you directly in touch with Liz at Team Gleason. And for anybody else who's looking to know what the services are for Team Gleason, they have a fabulous website, and I think they have a contact box that you just reach out to them and they will be right back in touch.
Thanks. That's great. And they are great.
Yes. It's my water cup. Yay, Team Gleason.
Let's move on. Lisa asks, does Medicare cover durable goods, which I verified is durable medical equipment. Specifically, she's asking because she needs a night breathing assist, an APAP.
Yes, absolutely. So there, if you go to medicare.gov and you know what we'll do, I think the better way to do this, because it's a little hard to find. If you go to medicare.gov and search for supplier directory, and we'll post the link on our website. But I think if you just go to put in the box supplier directory, most people wouldn't think to do that because, again, it's a little convoluted to find. But you go to medicare.gov, put in supplier directory. What you get is a screen that asks you for your zip code. And then once you put your zip code in, and then it asks you what kind of equipment are you looking for, or supplies. If you know with any specificity, there's a box for manufacturer. There's a box for like the code of the piece of equipment. If you only know, for instance, that you want a breathing device, then you can put in breathing device, and it will show you what types of breathing devices there are. So just as a piece of suggestion, I often say to people, the first thing that you're going to need is an order from the doctor. And the more specific the doctor can be in the order, the better off you're going to be, because if there's just you just need this breathing device, there's any range of breathing devices out there, right? So if the doctor says, the best brand is this brand, or model number, or any more specific information, the doctor should order that, because otherwise, typically what suppliers do is give you like the base model, the lower model. So with the specificity of the fact that you probably have some comorbidities, right? You probably have other issues that you may have a problem with secretions. So there's an importance that you have a specific model. Make sure that the doctor specifies that model. Okay, now let's go back to where I said you go to the website, you put your zip code in, and then you put as much information about what you want. It's going to narrow the number of suppliers that will pop up that serve your zip code, that have that specific model of breathing device that's been ordered for you. So yes, Medicare covers them. Medicare covers the, okay, let me back up, because again, this is important. When you put in your zip code and you put in the model number, and this number of suppliers pop up, you're going to see that there may be a supplier that's 5 miles away from your zip code, and there may be a supplier that's 500 miles away. And you may think to yourself, why would I pick a supplier that's 500 miles away from where I am? Well, you'll know within a few minutes of contacting these suppliers whether or not they've got their acts together. And quite frankly, some of them don't. And so the supplier that's 5 miles away from you, you may be put on hold. They may, be unsure. Do we really carry that model? You can tell. And on the other hand, the supplier that's listed that's 500 miles away may have a customer service representative who will come to your home and do everything that you need to do. So sometimes checking out a few different suppliers, it can save you a ton of time in the long run. So again, what we find is that it's important to make a few phone calls until you're comfortable that you've reached a supplier who is going to help you. Okay, breathing devices are really a very interesting thing we work a lot with, because there's a lot of moving parts. The suppliers are required to deliver, set up, and train you on the breathing device, any device, but particularly when you have a breathing device, you may need a certain calibration, and there may be a card, and you may need to have a mask, and the mask needs to fit properly. So there's, again, a lot of moving parts to this, and it's really important through each stage of the process of getting the right device, whether it be a breathing device or another device, but making sure that the supplier is going to do the follow-up. They're also required to repair and maintain the device for you. That's part of the Medicare payment. So it's kind of an all-inclusive process by which this durable medical equipment is covered by Medicare. But in the grand scheme of things, if people need supplies or equipment and it's a medical need, then there's a lot of opportunity to have those items covered by Medicare.
Great.
Thank you very much.
Sorry, long-winded answer.
Nope. I'm going to change tacks a little bit. I just got a question, which is actually a repeat of a question that happened earlier, and this blows my mind. The earlier question is, why do agencies say they don't cover home health aides for ALS? And the current question that just popped in was, I was just told by my home health agency that Medicare does not pay for home health aid services and has not paid for them for years. They said the home health agency provides the aid at their own cost. Is that true?
So I can take this one. That's not true. Medicare does pay for home health aides. They won't pay for home health aides if that's the only service you need. Home health aides are a supplemental benefit that beneficiary can receive after they've qualified for home health services. So they meet the criteria, they need some type of skilled care. They are eligible for home health aides in combination with skilled nursing for up to 28 hours per week, and sometimes in exceptional circumstances up to 35 hours per week. That isn't what we're hearing. We're not hearing that that's actually happening in the community. We're most often hearing that beneficiaries are receiving 2 visits, 3 visits, definitely fewer than 10 hours per week of home health aid. We think that this reduction in home health aid services is based on payment structure, and how that there's an incentive to provide other services rather than home health aid services, and that at a certain point, maybe somewhere around these 3 hours per week, home health agencies are realizing that the reimbursement isn't worth paying a home health aid. So unfortunately, when we speak to beneficiaries who are trying to receive more home health aid coverage, they often hear, well, one, if they're saying that Medicare doesn't cover that, that's not true. If you're receiving skilled services, then Medicare does pay for home health aides. We're also hearing home health agencies saying that they don't have the staff for that. And unfortunately, there isn't any hook currently to ensure that home health agencies have a sufficient number of home health aides to service the beneficiaries that they're serving. So if the home health agency says that Medicare doesn't pay for home health aides, show them the law that says that it is covered. Unfortunately, if they say that it's staffing reasons that they can't supply the home health aides, we'd recommend possibly reaching out to other home health agencies, again, looking on Home Health Compare and seeing if there might be other agencies who have the ability to provide more aid hours.
Yeah, and I'm going to address this as well from a little different perspective. So first of all, those kinds of stories, please just quickly write a note to our home health at medicareadvocacy.org email address. We need to have a flood of those kinds of responses because we need to fix it. And I'm going to address the question that Maddie answered from the perspective of the home health agency, because we talk to a lot of home health agencies. And there's a long history, but the short story is that about almost 20 years ago, Medicare went from a fee-for-service payment to a bundled payment. So as a home health agency, I'm going to get a bundled payment for the services that I provide. And if I provide more skilled services, I'll get a little bump in my payment. For every additional a couple of therapy visits, for instance, I may get a little more payment. There's no extra payment for whether or not somebody gets 3 hours of a home health aide or 30 hours of a home health aide. Typically, the home health agency is going to get the same bundled payment. So they don't look at, the intent of Medicare was to bake it all into the bundled payment and basically say, okay, there's going to be some people that don't need home health aides, and there's going to be some people that need 35 hours a week of home health aides. The coverage law, as Maddie said, is correct. The coverage is truly in the law that people should be entitled to 35 hours of home health aide a week if they meet the Medicare criteria. And we know that many people with ALS absolutely meet that Medicare criteria and should be getting the services. But the agencies are looking at this like, well, we don't get any extra payment. We get this bundled payment, and no matter how many times we say to them and to Medicare, it's built in. It's built in, and it's meant so that the whole idea of a bundled payment was you're going to make money on some patients, you're going to lose money on some patients. This payment system is horrendous. It's not working. It needs to change. And it's clear because when the payment system went into effect, that almost 48% of the services that were provided by home health agencies were home health aides. Now it's down to less than 8% of the total services that are offered by home health agencies are home health aides. So we understand that it's happening. The statistics clearly show it's happening. And it's not fair because it's in violation of the coverage laws, the payment policies. So we're screaming as loud as we can. We need to hear the stories so that we can take those stories. Trust me, the home health agencies, they as long as they get paid, this is not their fight. This is our fight, the beneficiaries. And there's a lot of people that are talking really loudly, and there's not enough beneficiaries because there's certainly millions of beneficiaries, but there's not enough kind of oomph behind it. So we are one of the few groups that's really attacking this and trying to bring awareness to it and trying to listen to stories, trying to gather stories. So I get this. People with ALS don't have the time or the energy to fight this fight. We're trying to fight this fight, but we're trying to give enough information because there are good guys. There are good guy home health agencies out there who are willing to, first of all, to provide we hear stories about people who are getting up to 35 hours of home health aide a week because they need them, and the home health agencies know that. A lot of home health agencies just tear the bundle apart and say, okay, we can provide you with the Medicare coverage. Medicare will pay for the skilled services. If you want home health aides, you pay for those out of your pocket. That's not right. But that's what these agencies are doing. And again, we need those stories. We need to be able to show Medicare that this is a huge problem. And we continue to talk about it, and they continue to say, well, that's anecdotal. That's not happening everywhere. It is happening everywhere. So those stories are really, really important. But we know that that's not your fight, right? That's our fight. And so how do we help you to get as much as you can? Again, we have in talking to agencies, sometimes they're more willing to help and participate than others. The other big obstacle for people with ALS in home health agency settings is that there are these quality standards that home health agencies are now getting rewarded for. And the quality standards, 5 out of the 9 quality standards that are out there look at improvement. Is someone improving in their ambulation? Are they improving in their bathing, independent bathing? And it's just not realistic to think that people with ALS are going to improve in these standards. And so home health agencies kind of sometimes look at that and say, well, we can take this ALS patient, but it's not going to help us to win on the standards. So we're trying to get the standards changed to really to equate to what somebody with ALS has, and because those services are covered under Medicare.
And that being said, I mentioned searching on Medicare Home Health Compare, and it also lists the home health agency's ratings on there. And those ratings, again, are based on improvement. So when you're looking on the website, the best star rated home health agency might not be the one who's best to care for you. So again, take those ratings with a grain of salt, because they don't apply to the entire population. They apply to those who are improving primarily.
Yeah, we're trying to fix it.
And speaking of good guys, thanks again to Team Gleason for recognizing this issue and throwing some support behind our efforts to make some headway against it. Can I ask a follow-up from Mark on aides and services provided? So say you can get a home health aide. Say the agency then says that the home health aide can only help with showering. What about meals, shopping, appointments, anything else? Is that correct? And if it's not, how can we get the agency to have the aide provide a little more help?
Okay, I'm gonna let Maddie answer that, because I have a list that I'll read when you're done about what's covered specifically.
Yes, is that from the benefit
Oh,
policy manual?
Yes.
Yes. So we have heard that and sometimes they're referred to as the bath girl. We've heard from other people commenting on that the only services that they provide are for bathing. While this isn't true, they can help with transfers, grooming, dressing. They're not just to be restricted to bathing. It's for personal care items. And so the benefit policy manual, chapter 7, which discusses home health, discusses those aid services that include personal care. And so they include bathing, dressing, grooming, caring for hair, nail, oral hygiene, as well as feeding, assistance with elimination, assistance with ambulation, changing positions in bed, transfers. So you can get the full list again at the policy manual, but it's more than just bathing. And this is a common quote that we hear, that they're strictly for bathing.
Yeah, and to Mark's point, the definition of a home health aide that's paid under Medicare is for hands-on personal care. So all of the items that Maddie listed, again, hands-on personal care, and they do expand coverage for things like doing laundry, if it's personal laundry. So pajamas, clothes, bedding, that type of thing, incidental to personal care. Another thing is fixing small meals. So I will say that one of the things that has become a problem with Medicare home health aides is the definition of personal care assistance. So whereas when we said that the Medicare home health aide coverage is for hands-on personal care, Medicaid will pay for a personal care assistant. And personal care assistants can do things like go grocery shopping, take people to appointments, do cleaning around the house, fix meals, that kind of thing. Medicare doesn't go as far as to cover those items right now. I know that there's a move afoot, if you will, among a lot of ALS advocates who we wish we could see an equivalent between what's covered under Medicare and Medicaid. That's another step in this process, but for right now, we're just trying to make sure that what's already in the Medicare law about what what a home health aide can do. As Maddie said, those hands-on type of care, getting somebody, and oftentimes ideally what will happen is someone will come in for a couple of hours in the morning to get somebody up and toileted and groomed and ready to go and kind of it's situated, and then come back for a couple of hours later in the day. That's kind of the intent of, if you look at the 28 to 35 hours, the sense that somebody would come into the home and help with those types of things, but again, under Medicare's intent was not to pay for the shopping and the taking to appointments and those kinds of things. So that's the distinction.
And also to add just about home health aides in general, if you are living with someone else in the home, this doesn't disqualify you from receiving home health aides. The law states that if you have a caregiver in the home, well, there's a presumption that there's not a willing and able caregiver. So, for example, if the beneficiary, an 85-year-old man, qualifies for home health services and thus home health aide, and he lives with his daughter may be uncomfortable and so unwilling to provide bathing or some of these personal hands-on care activities. So just because there's someone in the home, that doesn't disqualify you from receiving home health aide services.
Right. We hear from a lot of people who say that the home health agency says, well, because you have someone in the home that can help you, or we'll just send someone in to train someone else in the home and then we have to leave. That's just, yeah, as Maddie said, that's not true. It's presumption in Medicare law that there is no willing and able caregiver unless someone steps up and says, okay, I am willing to be here on these days and during these times, but otherwise I'm not willing or able. So.
Thank you both. Moving away from that for a little bit, David's been waiting patiently with a question on payers of last resort. He asks if he has a long-term care plan and Medicare, which would be required to pay for in-home care. Is Medicare always the last resort for both medical and home support services?
Okay, so I'll take that one. And my first piece of advice to you is to go onto Medicare.gov. There's a fabulous, and not always, Medicare material is not always fabulous, but this one is really good. There's a fabulous publication called Who Pays First. So go to Medicare.gov and in the search engine, then you just type Who Pays First. You'll get this booklet that will come up. It's a PDF and I don't know, it's probably about 30 pages long, but there's a lot of charts in there. And the thing that makes it a little tricky and the thing why this document is so helpful is that I'm going to say it depends. So it depends on who pays first based on if you have the long-term care insurance through, well, that's health insurance. I'm sorry, I'm kind of goofing it up a little bit because you're asking about long-term care insurance and I'm thinking in my head about health insurance. So let me just answer that question about who pays first. Who pays first? If it's health insurance, this book gives you a lot of sense of if you have health insurance through other than Medicare through another provider, it may depend on how many employees. They have like large group health plans and smaller group health plans. And anyway, so the book is helpful for that, but I'm sorry, I went and took a tangent on your question. So the question is about long-term care insurance. And I always say to people, call your long-term care insurance company and let them know that you have Medicare because it's every policy is written differently. So there are rules around health plans for sure that are in the book that I told you about, Who Pays First. But when it comes to something like a long-term care insurance policy, we've seen enough of them to know that every policy is written differently. And typically, the long-term care policy will defer to government benefits. So if somebody has both Medicare and the long-term care policy, then they would expect for Medicare to pay the first 35 hours, for instance, if that's what the doctor's ordered. If say somebody needs a 24-hour home health aide, they need somebody there to monitor their personal care, make sure that everything is working properly in their equipment. So they need 24/7 home health aide. Medicare should pay typically for 35 hours, and then the long-term care insurance would pay after. The policies may be written differently. So check with the policy. And then, quite frankly, Then there's the home health agencies. They step in and they say, they look at it and they go, oh, we're not going to get any extra money from Medicare, remember, because it's this bundled payment thing, and they're going to pay us the same. They're not going to pay us any more if we have more home health aid hours. So their MO is to, and I'm not trying to trash home health agencies. It's a bad Medicare policy. But in any event, they may want to bill Medicare essentially for the skilled services and take that bundled payment, and also bill the long-term care insurance. We hear about that as well. The problem is that a lot of these long-term care insurance policies have a maximum amount of benefits, and then people are racing through the benefits that are covered under the policy. There may be, not an unlimited benefit, and so there's a concern that they may exhaust their long-term care insurance benefits. So again, check with the long-term care insurance company. But I think for the most part, we have to resolve this issue of how home health agencies are reimbursed for home health aid services, and that will help take the pressure off of what's happening with the long-term care insurance policies. And just as another thought about that, I'm really surprised in some ways that the long-term care insurance are paying. They seem to be paying, but technically, Medicare should be doing their part and covering a certain amount of these aids. So it's a little confusing to me why the long-term care insurance policy folks haven't put up a stink about them covering. But again, you don't want to rock the boat, because you don't want them to say, well, we're not paying anything, or we're going to carve out the first 35 hours. So it just becomes a tricky situation. Do you have anything?
No.
Okay, sorry.
Thank you. I think we've got time for one or two more. How about a specific question that speaks to skilled services, I think. Jill asks, if a person has a trach or a peg tube, what kind of care would be paid for, since that certainly seems like skilled nursing would be needed?
So you want to?
You have more experience with trach care. So
yeah, I want to, so this is the tricky thing with home health care services. Medicare is limited to intermittent skilled care. So if somebody needs skilled care 24/7, and a lot of people do, unfortunately, then Medicare is going to say, we don't cover anything for home health aid. I'm sorry, I have home health aid in my head, but anything for home health, because the criteria for home health is that the skilled services must be needed on an intermittent basis, not a constant basis. So then you get into this kind of tricky thing about, I have a son who has a G-tube, and so we were able to get some services for them, but we had to carve out the feeding, for instance, because the home health aid was not able to, was not allowed to feed him, because that's a per se skilled service according to the state. Anyway, that's neither here nor there, other than the fact that I'm just trying to illustrate the point that there are some services that are covered by Medicare, and some that aren't. And if somebody needs constant skilled care, then Medicare is not going to cover those services, unfortunately. And I don't know if that answers the question, but and just to continue that thought, sometimes people can use unskilled workers to help with the services, and then can kind of put different scenarios together. It's a tricky situation. And this is another one of those situations that probably 90% of the people on the phone already know the answer to this question. So if you have any other advice or thoughts that would help Jill, please send them to us, and we'll make sure that she gets your feedback.
Thank you. We're at 4 o'clock, but I wonder if we could do one final question that sort of takes us all the way back to the beginning. And that question is this. Okay, I'm feeling a little ignorant. I know now that I do qualify for Medicare, but how do I start it? Do they initiate it? Do I?
So the best way to initiate it is to file a Social Security disability claim. And I should caveat that with saying it depends. If you're under the age of 65, then you can only get Medicare if you apply through the Social Security program for disability, and then will qualify for Medicare. If you're over the age of 65 and you've aged into Medicare, then you don't need to go through the disability process unless that's something that you need to have anyway. But when people are over 65, they typically don't qualify for disability because it morphs into the retirement benefit. Although that's not true. I'm going to stop for a second there because now the age of retirement, the full age of retirement with Social Security is 67. They haven't changed the age of Medicare. So if you are over 67, you probably already have Medicare anyway. So sorry, that was a really roundabout way of answering that question. Hopefully I answered that question.
And then once you have Medicare, the next step would you need an order from your doctor for the skilled services, for the home health services. And following that, you'd want to reach out to some home health agencies. I mentioned Home Health Compare, and the home health agencies will request the order from the doctor, and they'll make a home visit and make their own assessment to determine what services they think you qualify for, what services they're able to give you, and they'll work with your doctor then to produce a plan of care, and your services should start soon after that.
Great. And then we'd also invite your friends. We're going to do this next month. I know Matt's going to close up for us, but we would love to continue to have conversations. We'd love to have people share their stories, and please join us next month and in August, and hopefully we can offer some more information.
Thanks for joining us today.
And thank you both. As I mentioned, we're a little bit over our time limit. I know we still have questions in the queue. We will take those. We will get some answers together for those, and we will present them at our next town hall, which is Wednesday, July 11th at 3 o'clock Eastern.
Okay, Matt, I'm gonna I'm sorry. I don't want the poor people who have asked questions to wait for a month. So the questions we have now in the queue, we'll answer and get those out soon, and then we'll share. We can reshare them on the webinar or the.
I suppose we could offer answers to these actual people first.
Okay.
All right.
We're just worried
because Kathy said so. You guys will get your answers by email. That'll come from me in the upcoming days, and then we will discuss them live next month. And we do encourage you to join us again. Please do tell your friends, spread the word. We have one July 11th, another the second Wednesday of August. And a big thank you to Madeline and Kathy for taking this on live without a net. This was a new experience.
Thanks, Gleason.
And thank you always to Team Gleason for standing behind us and supporting this initiative. It's incredibly important. And on that note, please get your stories in on the note that of importance. Nothing's more important than us being able to tell the stories and problems that you're experiencing, and we can't do that without you sharing them. So please spread the word. homehealth@medicareadvocacy.org. Get us those stories. Thank you all, and I will conclude today's presentation.
All right, thank you.
Thank you.